see now, sir? Yeah.
Yes, madam, yes.
So this is pediatric respiratory ECMO. And then, as I said, what ventilate, oscillate, or cannulate is the dilemma. And now we are definitely going to cannulate. That's much we have decided. So this is the ECMO outcomes, ELSO for pediatrics. You can see for pediatric respiratory, it's about 61%. And for ECPR in pediatrics, it's 42%. So, which is fantastic considering, and for neonates, it's around 73 for pulmonary indications, your meconium aspirations, etc. This is the ELSO data. And this is fantastic considering that these patients are the sickest of sick patients with the 80 to 100% mortality. And if that's converted to 61% survival to discharge and an ECPR of 42%, that's really some great. So, but to have good outcomes, it's timing. I'm sure you've heard this a lot in the last day, yesterday. So timing is the key. So also in pediatrics before multi-organ dysfunction. And in neonates, 14 days is accepted. In pediatrics, it's about 10 days. I know in adults, it's about 7 days. But the longer the patient is subjected to high ventilatory pressures, high FiO2, which is equally bad, then your lung changes are a little more irreversible and outcomes could be poor. So it's the key is to initiate it early before there is, ventilator-induced lung injury. And shifting to a hospital for ECMO would make sense rather than shifting when it's too late. I mean, patient may not even be shiftable because of the high ventilatory pressures and oxygen requirement. So early ECMO referral. So this was a pediatric ECMO transport. So the patient was cannulated there for hypoxemia and then brought by our own team. You can see Dr. Madan here. He'll be giving a talk. So he cannulated it in the referring hospital. Recently, I don't have the pictures. I think everybody was so focused on keeping the cannula of a newborn in situ to size 8 and 10. So I don't have pics, but neonate was transported, cannulated at the referring motherhood hospital and transported, ECMO transport to our place. We have decannulated and child is doing better on regular ventilatory support. So transport ECMO can be done in pediatrics. And we have this ARDS criteria. So for those adults who are not familiar, this is the PARDS. And since it's very difficult to, put an outline or get frequent sampling, especially for neonates and small babies, there's something called SF ratio, where instead of PF, we substitute with your SATS ratio. So SF and instead of OI, your OSI, where instead of PaO2, the SaO2. So what is severe ARDS? When you say OI of 16, it's OSI of 12.3. And a severe SF ratio of less than 260 is equal to a PF ratio of around 300. So just to give you an idea that you can look at the SATs and still you can say whether it's severe ARDS or not. And ECMO should be considered when the risk of mortality reaches 50%. So the indications in pediatrics, you have ARDS for whatever cause, trauma, etc. Your viral bacterial pneumonias, aspiration pneumonia, status asthmaticus, where the CO2 is, very, very high. Your mediastinal masses, air leak, airway surgeries have been done on ECMO, and of course, any procedure. So indications like in adults, adults have the Murray score, we have all these, and it's not just one criteria. It could be any two in a matter of 4 to 6 hours, and then you should be thinking of calling for ECMO. So oxygenation index. Now, many centers across the globe are not waiting for 40 of OI, even at 25, because you've already approached a 50% mortality, and it increases with a rising OI. Ventilation index. Now, CO2 can also be a problem, which can cause, acidosis, RV dysfunction, worsening shock. So ventilation index more than 40. Lack of response to conventional mechanical ventilation, all your proning, your HFO nitric, elevated ventilatory pressures, which is your unconventional more than 30 MAP, and in HFOV 30 and conventional about 20 to 25, iatrogenic barotrauma, PF ratio, hypercapnic respiratory failure, and rate of deterioration. So this is a study which showed that an OI of 33 was a reasonable cutoff for calling for ECMO. So not waiting to 40. Many centers, of course, do it. ECMO centers do it at 25 also. And as I said, this is the oxygenation saturation index, which replaces the PaO2 with your SaO2. So MAP into FiO2 by your times 100. And what is ventilation index? This is your respiratory rate into PCO2 into PIP by 1000. More than 40, do consider ECMO. So this is ventilation index and outcome in children. So we have an ECMO checklist, and every center should have this ECMO checklist for both respiratory indications and cardiac indications for ECMO. And presence of any two criteria over a period of 4 to 6 hours, despite maximal medical resuscitation, you should raise the alarm and call the ECMO team, alert the ECMO team. Obviously, the ECMO team is alerted much well in advance so that they have all the cannulas ready. Other indications are foreign body aspiration, your burns, respiratory failure, tracheobronchial trauma, pertussis, hydrocarbons, so kerosene aspiration, etc. Newborns, meconium aspiration, very good outcomes. Congenital diaphragmatic hernia depends on the degree of pulmonary hyperplasia. Then, of course, the other indications, respiratory distress, air leak. So it's no different. And the way of weaning, the way of ventilation are all similar both in pediatrics as well, newborns as well as in adults. So as you can see, the contraindications are shrinking. Even for immunocompromised patients, this was one child we did for SCID, severe combined immune deficiency, who had just undergone a transplant, parents could afford. We decannulated, but the patient before and succumbed to another infection. So extracorporeal membrane in immune-compromised patients, avoiding the incurable RV missing. So there is really no contraindication if the underlying disease is curable, patient is salvageable, and patients can afford, we should be offering ECMO. However, there are risk factors for poor outcomes, especially if they have been on high ventilatory pressures, they have multi-organ dysfunction, more infection. BA ECMO was little worse outcome compared to BB ECMO because they are more sicker. So how do we prognosticate? So like in adults and newborns, the ELSO registry has these scores, very easy to feed in all your data. So you can objectively counsel your family and tell them that this is the risk for your child percentage, and it's very objective. So it helps counseling families. These scores are available in the website, ELSO website. So veno-venous or veno-arterial ECMOs for patients with respiratory failure needing ECMO. So in adults, you would say it is only VV ECMO. In pediatrics, less than 15 kilos, we would prefer VA ECMO, mainly because of the flows. The femoral veins are not well developed. So it's very hard to get enough flows from the femoral vein. And many times we've had to resort to 2 femoral veins, cannulas in 2 femoral veins to get good flows. So better to use veno-arterial, especially in very small children. Obviously in newborns, you would have to put only carotid and internal jugular, even for respiratory indications. Otherwise, it is veno-venous. We've had children referred to us in shock, pneumonia with bad ARDS, in shock on 4 inotropes. And it was, so we did an echo. It is mainly the RV, so it's not global dysfunction. The minute VV ECMO was initiated, in fact, from hypotension, the patient went on to hypertension and we had to give antihypertensives. So VV ECMO is used for pediatric respiratory failure unless you're worried about flows in small children. So that's what, even if they come to you in severe shock. Septic shock patients with community-acquired pneumonia, try VV ECMO because it's a lot easier, and then you can use a bit of your pressors, etc., along with your VV ECMO. And as the oxygen delivery improves, everything else also looks more hunky-dory. So how do we cannulate? We use the semi-Seldinger techniques because the vessels are very small. So we open the cut, do open cut down, visualize the vessel, and then do a Seldinger percutaneous technique. So it's done in the OT, where the lighting is better, more controlled environment, more space. We tried it initially in the pediatric ICU, but with such small children and small vessels, it was just too cramped. And you can see the perfusionist here, and this is the cannula being inserted. So VV ECMO, this is the 2 cannulae. So you have your deoxygenated blood. You can actually check whether there's recirculation or not. This patient, very important in pediatrics, you have to choose the cannula. So you have to tell your surgeons the weight of the child, because then you have to get the biggest cannula. and they have to reach your IVC, otherwise you would not get enough flow. So this was a child first initially with the drainage only from one femoral vein, and there was not enough, so we had to put the triple vessels, so 2 femoral venous drained and then 1. So this was a BV ECMO. And the patient was getting bloated because there was a lot of chattering and they kept giving fluids. And finally we realized, only way, look at the face, all bloated. The only way to sort this out, vicious cycle, is to put another cannula so that we don't have to, the flows are good and we don't keep giving fluid bolus in every shift. So this is an infant for ARDS. Femoral vessels are small, so this is a BA neck. This was our latest patients. I mentioned the transported baby, neonatal ECMO for meconium aspiration. And this was done in the other hospital, Dr. Madan and team. Dual cannula, no experience in India for pediatrics. Blood flow rate in neonates is about 100 to 150 and children's 80 to 120 mils per kilo per minute. And easy to look for recirculation, the color difference. This is, you can just eyeball and look at it. FiO2, so this is what are the mechanical ventilation in children or venous ECMO, what are the variables for mortality. FiO2, don't discount that. Keep a watch on the FiO2 that's on the ventilator, because every 0.1 increase in ventilator, the odds ratio is about another 1.3. And so that is also contributing to your mortality. What settings do we use? We know low FiO2. Apart from that, it's still the plus 10 on 10, rate of 10, low FiO2 on the ventilator, I time of 1. So ultra low tidal volume. There was one paper with adenoviral infections, I think in China, where they have given 3 mils per kilo of tidal volumes. But sometimes we've seen single digit. No point chasing those tidal volumes. We've seen we need to rest the lungs. It will take some time before it opens up. So don't push. Just use the PEEP to keep the alveoli recruited. Don't use high driving pressures. Deeply sedated. Pediatrics are a lot more, they are not cooperative, difficult to handle, so we paralyze in the first 24 hours, deeply sedate, control mode ventilation. After 48 hours, stop the paralysis, negative fluid balance from then on, if not in shock, and then try spontaneous mode of ventilation in about 5 days. Tracheostomy, not in neonates, not in small pediatrics. We can even keep the ET tube for about 3 weeks or so and look and check at least 2 weeks and see whether, how the lungs are, whether lungs are improving or not before taking a decision about tracheostomy. Now, are we PEEP-phobic? If the patient is very fluid overloaded, don't hesitate to recruit the alveoli with little more PEEP, because what PEEP you're setting on the ventilator may not be what the patient is getting when there is pleural fluid, when there is abdominal distension. Your true transpulmonary pressures are much lower because it's pressure in minus pressure out. So you can go up to PEEP of 13 or 14 if there's a lot of edema. To keep your alveoli recruited. That's something very, very important, because that's the only thing that's going to keep your lungs a little open. You're not going to use your driving pressure or tidal volumes. Spontaneous mode, when do we put on spontaneous mode of ventilation? When we do, we always use pressure support, and in pediatrics. We've tried APRB, but then that caused some pneumothorax, air leaks. So we are comfortable with pressure support. But remember, if the patient is having, asynchrony, taking deep breaths, then there's something called patient self-inflicted lung injury, PSLI. So and in ARDS patients is a lot more. So that can cause high transpulmonary pressures. That can also cause lung injury. So go back to sedation, keep the child paralyzed before you again consider a spontaneous mode. So for air leak, this is a child with air leak. Use the lowest possible pressure. So this child was managed only with CPAP till the bubbles disappear. And then after that, once the air leak sorted out in the next 2 to 3 days, then the pressures were slowly increased. Do not insert any ICD or if there is no hemodynamic compromise. You will convert a pneumothorax to hemothorax, or even there could be slow ooze over a few days, and then you will have a massive hemothorax which is compressing the alveoli. So one patient, we had to do a thoracotomy, stop all the heparin. So do not insert any ICD into these ECMO patients when they are on anticoagulation. PPs on ECMO. So this was a child with air leak. So rather than extubating the patient, because we need to keep kids sedated, they will pull out all your cannulae. So just the ventilator was disconnected or the patient was put on TPs. so there's no ventilator-induced exacerbation of the air leak. Proning, very easy on pediatrics. We call the perfusionist, we time it with the surgeon and flip the child over. So proning on ECMO is possible and it does help. Toileting. Awake ECMO, not in pediatric, but in neonates, since they're more easy to handle, we can do, so they're like adults. So we can keep the child a lot, comfortable. Pediatric patients get agitated, and so we have to sedate them. What sedation we use? We use both enteral and parenteral. We use, rotating sedation. So a combination of opioids plus benzodiazepine. Then after that, we have Dexmed and ketamine, and then we'll keep rotating. We use enteral lorazepam, chloral hydrate, etc. Because all of them do get withdrawal, and so we try to reduce that as much as possible. So we cannot, completely avoid withdrawal. Now, X-ray is very, very important because you have to look at the cannula position, and that can slip. Ultrasounds for knowing, to know whether there's fluid, which we do at the bedside. So this was a child, pediatric patient, who's, you can see this is the cannula day 0, and day 2, the cannula is actually migrated much higher and the flows were not good. So that was noticed a little later. So have to be mindful of your cannula. Echocardiogram is going to be discussed. I'm not going to think. We also do it in pediatrics to know whether to put on BB ECMO or whether VA. If there is global cardiac dysfunction, if there's like adenoviral pneumonia with adenoviral myocarditis, then it would make sense to put on VA ECMO. Otherwise, we would put only on BB. And of course, during weaning to know about RV dysfunction, etc. The usual indications for echo. Hypertension is more a problem on BB ECMO even for respiratory indications. And more than IV antihypertensives, we use a lot of enteral because I think some of it is sequestered or light inactivated, etc., or extracorporeal. So we use enteral antihypertensives because remember, these patients are anticoagulated. So they can be risk of intracerebral bleed, quite intracerebral bleed, and one would never know. So we have to aggressively control the hypertension, even on BV ECMO. Bronchoscopy, we don't share the bronchoscope, even though it's clean. We have a separate, because we're so worried about an infection, changing, pushing the child several steps backwards. We have disposable bronchoscopes which are available, a little expensive, but we use it only for that patient, even multiple times. Nutrition, already mentioned, but early enteral nutrition, started early. Fluid, get them negative, dry weight, and sedation I've already discussed. Tracheostomy on ECMO, not in neonates. Pediatrics, after 2 weeks, we would consider, but it has to be done in a controlled environment. The patient has to be taken to the theater, not so easy at the bedside. We can stop the heparin and then watch. But tracheostomy has been done at the bedside, and there are studies to also show that. Position change, it's 2:1 nursing, very intensive. So back care, a nimbus bed is always put even for pediatrics. One is to monitor for infection, and we do all this position change, back care with a big team involved. So not solo. So we wait for the perfusionist to come, cardiothoracic surgeon, and everything is done at that time of the day. So nursing team makes a lot of difference. Please train your nurses so that they're more comfortable and have all these checklists. Weaning, the same as was discussed before by Dr. Vivek, so I'm not going to discuss. Same principles we follow even in pediatrics for weaning off BB ECMO. We don't reduce the flows, we only turn off the sweet gas and cap the oxygenator. In survival after ECMO for respiratory failure, very good. There are even in this country, many of my colleagues have done ECMO for even 6 weeks, and patients have come off for respiratory ECMO. So lung has potential to heal. BA ECMO has a little more complications than BB, but the underlying disease is what determines the outcome, whether it's immune deficiency or a transplant, etc. And apart from the choice and the timing, your anticoagulation, your ventilatory strategies, fluid management, dialysis, all this make a lot of difference to your outcome. So timely ECMO for refractory hypoxemia is life-saving. We have data even from our subcontinent. Outcomes are poor if instituted after irreversible ventilator-induced lung injury, and we have all learned it the hard way, the before ECMO era and now. And BB ECMO is preferred for ARDS hypoxemia, even with shock, except in very small children. Thank you. Happy to take any questions.
Thank you, Dr. Indira. It was a lucid talk. Now we are running a question answer session. So your inputs are necessary.
So there's one question from Dr. Karen, and he asked about pulmonary hypertension on VV ECMO and how to manage it. So, see,
So it's not very audible, sir.
just a minute. Yeah. Am I audible now?
Now you are audible, sir.
Okay, fine. So there was one question from Dr. Karan about the pulmonary hypertension on VV ECMO. I think that question was addressed to me. So,
нормальная частота. Есть, ну, как бы, норма 55. Может быть, сейчас 50. Я не помню, какие. Оно поменялось чуть-чуть. Нет, было 60, потом, по-моему, стало 55 брадикардия. Норма брадикардии.
yeah. So, see, for a long ECMO, especially when we are shown during the COVID time, so long-standing ECMO do have developed pulmonary hypertension and subsequent right heart failure. So the management, what we usually prefer to do is first the drug. The first drug of choice usually we give is dobutamine with noradrenaline support. If the blood pressure is low, we combine dobutamine with noradrenaline. क्या हो रहा है? Can all of you mute yourself? Yeah. So the first drug of choice usually we prefer is dobutamine with noradrenaline support. If the pressures are low, if the pressures are fine, with just dobutamine will be fine. Some people you do use Mineriron instead of dobutamine as a first drug choice. Even in adult patients with VV ECMO and pulmonary hypertension with RV failure, we do use the inhaled nitric oxide, and the dose we usually titrate from 5 ppm to maximum we go up to 20 ppm. There are multifactorial factors which affects the cause pulmonary hypertension. One of them is the triggering factor. Most of the time is the new infection. So the moment you control the new infection, probably the pulmonary hypertension also comes under control, and till that time you have to support the patient. So the first drug, as I told you, is we use is dobutamine with noradrenaline. The second is inhaled nitric oxide. And third thing, if that also doesn't help, we convert the patient to VVA ECMO for a time being, till the time the right ventricular function improves, and then we again switch back to VV ECMO. Okay. Any comments? Or Dr. Karan, you have any further question?
There's a question, sir, on what's the experience of awake ECMO in children? How feasible is this? So it has been done overseas, but it's very intensive. We don't have enough nurses also to manage the regular patients. So they would pull the cannula. You have to really closely watch. But there are papers stating that even less than 1 year, awake ECMO has been done in pediatrics.
Question ke liye unne kiya
At KIMS also we did it, Indira.
Ah.
Depends on the
type of the patient, how they cooperate.
How old was your patient, sir?
2 years old.
2 years old. Fantastic.
Me and Nanda will be sharing. Sorry, some disturbance coming. Me and Nanda will be sharing our pictures now and then. Yeah, yes, it can be done in children, and we have been doing it in KIMS also.
Oh, that's nice.
There was one question, okay, what is decaping? Decaping is when we disconnect the oxygen pipeline from the oxygenator, that is what we call as a decaping. So when we give a trial for the VV ECMO and even for the VA ECMO, we remove the oxygen from the oxygen or the sweep gas from the oxygenator, and that is what is known as decaping. Any other questions? Yeah. Yeah. There's one question that how do you put a bridge in the VA ECMO when we give a trial of? Okay. So again, there's a workstation on that. On 17th of this during the session. That time we'll teach you how to put a bridge. But usually we connect the bridge between the vein and the arterial limb that is close to the cannula. So the use of this bridge is when we clamp the cannulas, okay, the blood will keep on circulating in the circuit so that it doesn't get clogged in the circuit. So that is usually we keep the bridge as close to cannula as possible, and that will help to keep the circuit patent. Okay, so that there will be a practical demonstration of that when we do a weaning and trial of. Okay.
So one more question I think somebody has asked. When we use VVA ECMO, both femoral access, second cannula will be of smaller size. Where do we position the tip? Priyanka has asked.
I didn't get the question, madam.
Dr. Priyanka has asked a question in the chat box, sir. When we use VVA ECMO with both femoral access, second cannula will be of smaller size. And where do we position the tip of that?
Yeah. See, when we convert into a VVA, okay, usually when we talk VVA, it means that case the two vein, and then we convert into it was a VV ECMO initially, and we convert into a VVA. So we put an arterial component. So if both the cannulas are in the femoral vein and jugular vein, that's fine. We keep it in the same position, and we just introduce an arterial cannula in the femoral artery. So that configuration is going to remain the same. If to start with both were femoral, then usually the first the drainage cannula remains somewhere in the hepatic IVC, while the return cannula goes up to the right atrium. And the size is usually we put around 25 French as a drainage cannula and 21 French as a return cannula. That is usually what we use. But again, if it is VVA, that both the cannulas were already there. We are just introducing one more arterial cannula. Now, if you are talking about VAV, means the VA ECMO gets converted into VAV, then usually we prefer to put the jugular cannula, because jugular cannula has not been used. So we prefer to put another cannula in the jugular. Okay.
Yeah, sir, I was asking, like, if you have a femoral and other arterial access, and by chance we wanted to put one more femoral in the the other femoral. So obviously the first femoral access would be till IVC. So whether the second one, because obviously IVC may not be able to accommodate two accesses. So in that case, what is the length and where we place the tip? That's what was my question.
IVC is big enough to accommodate another cannula also. So when we put usually when we do femoral ECMO, VV ECMO, we always use 25 and 21 French. So you can always put another around 21 French cannula in the femoral opposite femoral and let it go to enter the IVC. If you don't let it go to the IVC, and if you keep it somewhere in the common iliac or something, the flow may not be appropriate, you may not get an adequate flow. So it's always better to let it enter the IVC, and you can keep it in the IVC.
There is a question, role of ECMO in hyperferritinemic states with respiratory failure, refractory to conventional ventilation and lung protective. It was asked to me directly.
Yeah.
So the indications of ECMO would be the same. For a refractory hypoxemia or refractory shock, you would initiate ECMO, regardless of the etiology, because now you want to save the life. And then you have to address the underlying cause and the hyperferritinemic state. So maybe you'll have to initiate plasmapheresis, CRRT, your immune modulation, etc. So ECMO is to give you time. It's not the treatment. So it just buys time while you address the underlying problem. So the role is to keep the child alive while you give you time to address the problem.
Venous access, we are there in smaller children, they are directly going to VA ECMO, sir. Like where the heart is functioning normal, how to handle VA for respiratory cause? Like if they're...
Indira, question for you. When you said that if there are access issues in the pediatrics, even in respiratory ECMO, we use a VA ECMO. So the question is that how you manage VA ECMO for respiratory? Basically, how will you tackle the north-south syndrome and that?
No, that's a very, very brilliant question. So we don't use very high flows. So we have to do echo every day. We have to see how the heart is ejecting, look at the pulse pressure. And because we don't want the heart flow, there's a native flow as well as the ECMO flows. And you don't want that to happen. It is not so much. We don't use femoral arterial cannulae. So it's either you're talking about respiratory. So respiratory, smaller children will always be carotid and internal jugular. So that it's not so much a problem, but we try to avoid very high flows and targeting high saturations. We accept a little low saturations so that the heart is not pumping against a high resistance. Keep monitoring the pulse pressure, keep monitoring your echo, your valve opening, etc. As you said, you don't want too high afterload. And if there is hypertension, then that also, we use a lot of afterload. So we use levosimendan, we use milrinone, lot of afterload reducing agents, even on respiratory VA ECMO.
Okay. So basically, usually when the excess is an issue in neonates and pediatrics, and when they use VA ECMO, it is always a IJV and carotid that is cannulated. So you don't get usually north-south syndrome because of carotid cannulation. Only precaution, as madam said, is you have to adjust the carotid cannula. It has to be in the arch of aorta. It should not go towards the aortic wall. If it goes towards the aortic wall, the afterload increases too much and it can even damage the aortic wall. The flow can damage the aortic wall. So that care has to be taken care. And usually they don't give too much of high flow, because the moment you go on a higher flow, the afterload increases. And third said is they use the medical management part, milrinone and levosimendan, to reduce the afterload. Thank you, Indira.
Actually, the teaching from Bob Bartlett is not to be worried about carotid artery cannulation that much, including the adolescents and adult age group. That is Bob's argument. It doesn't usually cause intracerebral bleeds. So he says, just contrary to the conventional fears, says don't be too much worried about cannulating right carotid artery or the arterial access.
So one more question, how after ECPR, do we keep patient in hypo or normothermia? Ideal temperature management in febrile and post-CPR patients.
Yeah, there's a separate talk on ECPR after this. So, but usually we post-CPR, we always tend to give the patient hypothermic for at least 48 hours and see the neurological response. But there's one talk by Dr. Arpan on the ECPR. Okay, if there are no further questions, then I think we move on to the next presentation. And I think it is Dr. Pobanis on infection during ECMO.